Hello, hello. So I thought I'd share some of the interesting cases that I've had this year, and or at least like semi-interesting for me, uh, with the use of ultrasound, and basically the management of them very quickly to wrap it up. Um, this case has somehow made me do some research in order to kind of able to be able to provide a better care, the best care possible for the patients that attend our emergency department. Our case one, I'm just going to talk about just to show you a basic echo, and it was a very interesting case from my point of view. There's a young lad who came complaining of palpitation. I'm going to use this example to just show you two views of a normal echo, and then the management of AF. Basically, he was flipping in and out of AFib. We managed to capture it when he was not actually in AF, by ultrasound to assess an overall look, because the discussion is for someone who presents with less than 48 hours of symptomatic kind of palpitation and atrial fibrillation. Your treatment options are the rhythm or rate control. We're going to talk about this, and this guy, bear in mind, new onset, young patient, and if we're going to cardiovert him, what are our cardioversion options? First of all, let's have a look at a normal echo. So left ventricle outflow tract, right ventricle outflow tract, descending aorta, and left atrium. This is a parasternal long axis view. All right, moving on to the four chamber view. You see the four chambers here, very nicely beating. There's nothing massively abnormal there. So normal looking heart overall. So we gave this gentleman 50 milligrams of IV flecainide. He stayed in sinus rhythm and got discharged. The notes I wanted to talk about this is about flecainide is a 1C anti-arrhythmia drug. Works on sodium channels by reducing the excitability. Used as a pill in the pocket for paroxysmal AF. It's a big no-no in possible structural abnormal heart, and that's the reason the usefulness of a bedside echo comes in practice. BNF says 50 milligram oral can be repeated, but from my point of view, if you are repeating this a lot, maybe just DC cardiovert. Of course, synchronized DC cardiovert. Reviewing the European Society of Cardiologists advice, it can actually be given 1.5 to 2 milligram per kilo IV. Generally, advice from ESC is obviously if the patient is unstable, it goes without saying you should DC cardiovert them. If stable and less than 48 hours, it's advised to perform rhythm control management because it improves the symptoms. The discussion about electrical versus pharmacological in less than 48 hours is a combination of your patient and the doc's choice. You can actually, based on DCS guidelines, pre-treat with flecainide because it would increase the chances of your DC cardioversion work better. If more than 48 hours, obviously you're going to need 3 weeks of either DOACs or NOACs and then cardiovert, so that's just beyond the scope of your resource room, unless you want to keep them 3 weeks in resource. And what do I do? My management, if someone comes in, I'm sure they're new onset AFib. Obviously, we discuss with the patient. I discuss with the patient in terms of what they want. I would probably load them on flecainide to prevent kind of like the aggressive sedation and stuff like that. Initially, if I don't need to, and I probably just echo them to see if they're not running terribly fast, to assess for obvious structural abnormality. And if flecainide fails, we're going to DC cardiovert. Just to note, this is my normal practice, and actually ESC advocates that there's actually AP pad positioning for DC cardioversion in AFib. So that was case one.